Hello, everyone. We'll go ahead and get started. My name is Alexia Torkey, and I'm Assistant Professor of Medicine here at IU and direct the Ethics Fellowship at the Fairbanks Center for Medical Ethics. So welcome to everybody from the Fairbanks Ethics Lecture Series. Before I introduce our speaker, I just have a few housekeeping notes. Please silence all your cell phones and pagers. I know it's hard to remember to do, but important. And if you do get called, please leave the auditorium to complete any calls. This lecture is being recorded and broadcasting, and so I'd like to thank and welcome all of you who are joining us from the other IU Health sites, including those at Riley, IU Health West, North, Saxony, Arnett, and Ball. So welcome to all of you, as well as the folks here in the room at Pettigrew. And now I'd like to introduce David Orentlicher. Dr. Orentlicher is the Samuel R. Rosen Professor of Law at the Indiana University Robert H. McKinney School of Law and co-director of the Hall Center for Law and Health. He also serves as an adjunct professor of medicine at Indiana University. A graduate of Harvard Law and Medical School, Dr. Orentlicher previously served as director of the Division of Medical Ethics at the American Medical Association. While there, he developed many positions on issues such as end-of-life decisions, organ transplantation, reproductive issues, and physicians' conflict of interests that have been incorporated into federal and state law and cited by courts and government agencies in their decision-making. He also held adjunct appointments at the University of Chicago Law School and the Northwestern University Medical School. Dr. Orentlicher has published Matters of Life and Death with the Princeton University Press, is co-author of the law school textbook Healthcare Law and Ethics, and more recently has a book coming out next week entitled Two Presidents Are Better Than One: The Case for a Bipartisan Executive Branch. He has written widely on critical issues in law and medicine, including healthcare reform, reproductive technologies, and organ transplantation. Dr. Orentlicher also served in the Indiana House of Representatives between 2002 and 2008. And during his 3 terms, he authored legislation to promote job creation, protect children from abuse and neglect, and make healthcare coverage more affordable. Please join me in welcoming Dr. Orentlicher.
Well, thank you, and thank you for having me today. What I'm going to talk about is the Affordable Care Act, what the Supreme Court did with it, and what the implications going forward. So I'm going to start, I teach healthcare law, I teach constitutional law. So I'm going to start with the Supreme Court's case, the challenge. And of course, the main challenge were constitutional challenges. The opponents, or the challengers, said that while maybe it's a good idea to have health care for all, you have to do it in a constitutionally valid way. And there were 2 problems with the way Congress set up the Affordable Care Act. One is the requirement that we all have to buy health insurance. And, we believe in individual autonomy, and where is the government able to tell us what to do and violate our autonomy? It's a good idea to be insured, but some people, we have the right to make bad decisions in this country. And then the other concern was the coercion of states with the Medicaid expansion. Because, the concern was by a number of states who sued, Florida and Virginia took the lead, but Indiana participated too, was that states were being forced to expand their Medicaid programs in an unaffordable way. So those were the 2 major challenges. Now, why do we even have to worry about this? Why? Because Massachusetts, tells people to buy health insurance. So we're going to start with the individual mandate. And Massachusetts tells people to buy insurance, and nobody had any constitutional problem with that. And the reason why is because while states have a general, it's called police power, but a general power to regulate on behalf of the public welfare or safety, they don't have, that's all they have to, if it's good for the public, that's fine. But Congress doesn't have that. Remember, our founding fathers were worried about a tyrannical national government. They were tired of King George III, and they didn't want our new government to do the same thing. So our national government and Congress are supposed to be government of limited powers, and if it's not specified in the Constitution, they can't do it. And there's nothing in the Constitution about health care. or health care insurance. And so where does Congress have the authority to write a law about buying health care insurance? And so what turns out is, for a lot of laws, a surprising number of laws, as it turns out, come under the Commerce Clause authority or the Taxing and Spending Clause. So under the Commerce Clause, Congress, the statute says, the Constitution says, Congress may regulate interstate commerce. And, healthcare is an interstate business, so that's how we get there. But it's interesting how many laws come under the Commerce Clause: civil rights laws, environmental laws, almost 90 criminal laws, the gun laws come under the Commerce Clause. So if you want to force people to do something, to prohibit somebody from doing something, Congress usually uses the Commerce Clause. And then sometimes it uses taxing and spending. If it doesn't want to force people to do things, they'll say, we'll give you money if you'll do something. So we'll talk about that. Okay, so now the challengers, it's not surprising they lost, really, because they had a tough hill to climb, because they conceded, everybody agreed, and they conceded that Congress can require everyone to buy health care from the government, the single payer. Right? That's Medicare for when we get older. So nobody disputes that we could have a single payer system. And so we could make you pay to the government for your insurance. Nobody disputes that they could say that when you go to the doctor or the hospital, the only way you can pay for your health care is with insurance. That's the Commerce Clause. When you're getting insurance, getting health care, you're engaged in a commercial activity, buying health care, you have to use insurance. So all Congress was simply saying was, instead of waiting until you go to the doctor to have your insurance, you have to buy it in advance. And instead of making you buy it from the government, we're going to make it you buy it from a private insurer. So if the concern is a too powerful government, why would we worry? Why would we say it's okay to have a government system, but it's not okay to have a private system? That's incoherent, which is why they lost. Okay, but we'll go through some of the details. All right, so here's the argument. Turned out the Supreme Court agreed with the challengers in one sense, and what they said was, Congress can't force you to go out and buy something. That's the individual, right? That was the argument. I'm just sitting, minding my own business in my living room, and the government wants me to go buy health insurance, and I don't want to buy it. And so the Commerce Clause, the argument here is the Commerce Clause says Congress can regulate economic activity. So what's an example of that? For example, if you're in the business of selling cars, Congress can say to you, you have to sell cars that get at least 30 miles per gallon. You have to sell cars that have a catalytic converter to reduce emissions. You have to sell cars that have seat belts and airbags. And those are all existing laws. And that's Commerce Clause, because when you're in the business of selling cars, Congress can regulate. But if you're not out there buying or selling something, Congress can't tell you what to do. And the court said, that's right. Can't regulate you when you're inactive, when you're not engaged in economic activity. Just sit in your house. Now, in fact, the problem with that was, how you frame it, right? The argument was you're regulating people who are inactive, but actually it's a regulation of health insurance companies. Why do we have this mandate? We wanted to say to insurance companies, no more discriminating on the basis of pre-existing conditions, right? Currently and until January 1st, if you have a heart disease or cancer or asthma, your insurer can discriminate against you. And Congress said, no, you got to charge everybody the same amount. You can't discriminate on the basis of health status. Just like in 64, the Civil Rights Act said you can't discriminate because a person is a woman or a minority. The Affordable Care Act of 2010 says you can't discriminate on the basis of health status. Now, of course, it's not fair to say to insurance companies, charge everybody the same amount of money, whether they're healthy or sick, and let people pick and choose when they buy insurance, because you'll just wait until you're sick to buy your insurance. Why buy when you're healthy if you know you can get it at standard community rates when you get sick? And it turns out when states had community rating, when Kentucky and New York and other states said to their insurers, you got to charge everybody the same amount, whether they're healthy or sick, people didn't buy insurance until they got sick and the market collapsed. So that was the argument. Congress is entitled to have a pre-existing conditions ban. Nobody disputes that. because that's regulating insurance companies who are engaged in economic activity. And the only way to make that work is an individual mandate. Well, it didn't work. The court said, no, you can't regulate. You can regulate activity, but not inactivity. And did we go backwards here? Yeah, somehow we went backwards. Sorry. So the court said, you can't force people to buy insurance directly. You're regulating inactivity. You can't do it indirectly by this necessary and proper clause. Okay, so you can't. So that's the first thing that came out of this principle. You can regulate people when they're buying or selling something, but you can't regulate them when they're not. Now, it turns out that's not going to make a dime's worth of difference in the future. It was supposed to be a big limitation on Congress. We don't have to worry about Congress telling us to buy broccoli or GM cars or all the things that we were supposed to be afraid of. But it turns out Congress can say to you, if they really want to buy you to buy something, they can say, for broccoli, when you go to the grocery store, you have to write to the grocer, don't check anybody out unless they have broccoli in their cart. They could say to McDonald's, from now on, when you serve that Big Mac, you've got to have a side of broccoli with it, because they're regulating economic activity. So it turns out Congress can really make us buy broccoli if they want us to. Fortunately, they don't want us to do that, so they won't have these laws. Or if they want us to buy a GM car, they could say to gas stations, you may not sell gasoline to anybody unless they have a GM car. And as I said, there are all those kinds of laws already. You can't buy a car without seat belts. You can't buy a television without a V-chip. So it turns out the opponents claim that Congress needed to protect us from an overweening legislature that was all ready to impose all these mandates. They really haven't protected us. What protects us is the fact that Congress would be nuts if they tried to force us to buy broccoli or GM cars. That they would get thrown out of office if they did that. Now the question is, if it's really so easy to pass purchase mandates, I've given you an example. If you want people to buy broccoli, tell the grocers they can't check them out if they don't buy broccoli. Why didn't Congress just do that? Why didn't they regulate people who are engaged in economic activity? As I said, this is about insurance. Insurance is a unique product in that you have to buy it in advance of your need. It doesn't make sense to have a law that says you have to have insurance when you go pay for your medical care, because then people will wait till they're sick to buy their insurance, and insurance doesn't work that way. It's like saying you can buy your homeowner's insurance after the flood or the hurricane or the lightning strikes. Homeowners, insurance companies wouldn't like that, and they won't let us buy it that way. So what was at stake here was not that Congress was looking for some new unprecedented power. It was that they were regulating insurance. And insurance is a unique product, as I say, and that you have to buy it in advance of your need. Okay, so the first point of the decision is the court really did say you can't force people to buy things when they're not already buying something else, but it's really inconsequential for two reasons. One, because they upheld the individual mandate to purchase health care anyway, and two, because any other individual mandate, as I say, is easy to justify. Okay, so how did they uphold the individual mandate? They did the taxing part, right? Because Congress, as I said, Congress can't force us to do things necessarily, but they can always force us to pay taxes, and then they can use that to spend for the general welfare. So how do we get the individual mandated task? Because it's supposed to be you have to go out and buy insurance. But if you look at it, how it's actually written, what it actually says is, effectively, basically, if you have to pay a 2.5% of your income to the federal government unless you own insurance. Right? And so, we need to raise money for health care for the indigent. We'll tax people. But if they're already paying into the system by having their own insurance, they're exempt from the tax. And that's functionally what the mandate looks like. It doesn't say, go buy insurance or go to jail. It says, pay 2.5% of your income or buy insurance. And so it kind of looks like a tax. And that's what the court said. Right? It's in the IRS part of the code. Now, there were some arguments about, well, it's not really a tax, because taxes are supposed to raise money. This is designed to coerce us to buy insurance. And it is true, if you go back to the 1920s and 1930s, the Supreme Court did draw a distinction between taxes for raising revenue and taxes to regulate us, to force us to do something. But they've abandoned that back in the 1950s because, first of all, how do you make that distinction? Take a cigarette tax. Is a cigarette tax designed to raise revenue, or is a cigarette tax designed to deter us from smoking? Turns out both, right? Less filling, tastes great, just like Miller beer. Same with the cigarette tax. It has two great purposes. We use our cigarette tax here to fund Healthy Indiana plan, and we also use it, as I said, to discourage people from smoking. So the court doesn't try to get into that distinction. If a tax raises any money, it's a tax, and we're not going to quibble whether it's designed really to raise money like a sales tax or it's designed to influence your behavior like a cigarette tax. The only thing is the tax can't be so severe as to be a criminal penalty, because that's what Congress used to do, and some states did, to try to get at people who are dealing in illegal drugs. When Congress wasn't sure they could prohibit the smoking of marijuana, they just levied a very high tax on marijuana to try to get people to prevent people from dealing in marijuana. And if it's a stiff enough tax, we'll say, no, this is really a criminal penalty in disguise. But we didn't have that here. So it's a tax. It looks like a tax, walks like a tax, right? Quacks like a tax. It's a tax. So that's where we end up. The individual mandate doesn't stand as an exercise of the commerce power. It stands as an exercise of the taxing power. It goes forward. Now, so one question is, if they can use the taxing power to get us to buy insurance, can they use it to get us to buy other things? And there were two things that the court said. One was, it wasn't a very stiff tax. It wasn't too onerous. It's only 2.5% of your income. And it's only for every month you're uninsured. So if you're uninsured for one day, you'll get taxed for 1 month income, but not the whole year. And they contrasted it with a Supreme Court case from the 1920s where Congress had passed a child labor statute. And the court had already told Congress they didn't have the power to pass labor laws. And that was overturned later. But before it was overturned, Congress said, okay, well, we can't ban child labor, but we'll tax it. And the court said, wasn't too happy about that. Didn't we tell you you're not supposed to regulate child labor, and now you're taxing? And so they struck it down. And what the concern was that it was a very stiff tax. Employers would have to pay 10% of their income for the year if they employed one child for 1 day. And of course, that's too much, 10% of income for the year. But for health insurance, it's only 2.5% of your income. And it's only part of the year if you're partly uninsured. The other thing is, that's the only consequence of not having insurance, is to pay the tax. Right? You either buy insurance or you pay the tax. But if you do either one, you're okay with the law. It's not like you'll be viewed as breaking the law by not buying insurance and paying the tax. It's not a fine. You don't have to, when you apply for a job, say, and they ask you, have you ever been found in the violation of law, convicted of a misdemeanor or felony, you don't have to say, yes, I didn't buy my health insurance, because as long as you pay the tax, you're good with the law. And in fact, the IRS can't do anything to collect that tax. Let's say you don't pay the tax. They can't put a lien on your house. They can't prosecute you. All they can do is withhold your refund. So one of the questions, will people evade it? But the important point is there's no legal consequences other than having to pay the tax. Okay, so on the important question, can we have this individual mandate? Can Congress say you have to have insurance or pay a fine? Yes, and that goes forward. And so And one thing I skipped over, how important was that? It was a big deal because people looked at what if they hadn't passed it? What if the court had struck down the mandate? And there were estimates that half of the effect of the Affordable Care Act would have been prevented. That of the 32 million people who are going to be insured because of the Affordable Care Act, we would have lost 16 million. That was the Congressional Budget Office. There were other estimates that ranged between 8 and 24 million, but on average, about 16 million. So it really was important in terms of making sure we have access to coverage. Okay, so now how are we going to get our insurance? Most of us will still get it from our employers. If you work for IU, things aren't going to change very much. You'll still get your IU plan. But if you have to get your insurance on your own, or if you're a small business person, you have to buy it for your employees, you'll be able to go to these health insurance exchanges. And the example I use is these exchanges are kind of like Expedia. You buy airline tickets from Expedia. Expedia is not an airline. It just creates this marketplace so American and United can list their flights and prices, and you can compare them easily. That's what Expedia says. You don't have to call up every airline and ask what their routes are, itineraries, and how much it costs, and make a dozen calls. Expedia puts it all together in an easily comparable way to compare them all. And that's what these health insurance exchanges will do. They'll say to insurance companies, if you want to sell your plans to the residents of our state, on your qualified plan, we'll list you on our exchange. If you've worked for the federal government, they sort of have their own exchange. The Federal Employees Health Benefit Plan, they list the different plans, or even IU, right? Every year, if you work for IU, you got 4 or 5 plans, and they do this nice table that helps you compare the different plans. That's what these insurance exchanges will do. Now, the big issue, the implementation issue, was who's going to do it? Because Congress said the states can set up their own exchanges, or the federal government will do it for them. Now, why did they do it that way? We're going to get to this a little bit with the Medicaid expansion, but there is this limitation on the ability of the government to tell states what to do. And as I say, we'll talk about that with the Medicaid expansion more. But Congress could not say to the states, you have to set up an exchange. That would have been unconstitutional. But what they can say is, you set up this exchange or we'll do it for you. So you're going to get the exchange, it's just you get to choose between whether you administer or we do it for you. And the government does this with environmental laws, it does this with a lot of statutes. Because, as I say, it can't force the state to do it. Why wouldn't the state do it? What's the downside? One is political. If you campaigned against the Affordable Care Act, it doesn't look good to start implementing it. Does it cost the states? No. There's no cost. And I think there are political officials, elected officials, who have misled the public and said it'll cost us too much money. No, the federal government provides the startup funds for the states that are setting up these exchanges, and the operating costs for the exchanges will be covered by the fees. The insurers that list themselves on the exchange will have to pay fees. So it'll be self-funded. So there's really no financial cost to the state. The main reason for state, why are some states not doing exchanges? It's, there are going to be problems, right? This is a new thing. Any time you set up a new, some kind of program, it's not going to work perfectly. So people are going to be unhappy. They've been promised they'll find an easy place to buy their insurance, and something's going to go wrong. And you might as well let the federal government take the heat for the glitches. Because after all, Congress passed the bill, so why should the states take the blame if things don't work out? So that's the reason. If there is a good reason for not taking over the exchange. Now the downside is the states, if they run the exchanges, they do have some control over how it's administered. The federal government sets some minimum qualifications for what the insurance companies have to be listed, but states can add additional requirements if they want. So you lose that kind of control. And my guess is what will happen is Indiana's letting the federal government do it now, but once the federal government has it up and running and works out the kinks, then Indiana will come and say, we're ready to take it over now. That's my prediction, and within a few years, Indiana will run the state exchange. Okay, the other big implementation thing is this Medicaid expansion that we've been reading about and hearing about, because our General Assembly and our governor are trying to decide, should we do the Medicaid expansion? And the important thing about the expansion is, under ACA, starting next year, all people up to 138% of federal poverty will now be eligible for Medicaid. And here's the graph: federal poverty. If you're a family of 4, federal poverty is about 22,000. So 138% is about a little over 30,000. So if you earn up to $30,429, and it's indexed for inflation, you qualify for Medicaid. And if you're a single person, you can earn up to about $15,000 and qualify for Medicaid. So that's a big change from now, because right now in Indiana, if you're an adult with a kid and if you earn more like than 24% of federal poverty, you don't qualify. So instead of 24%, you'll go up to 138%. The other thing that's important is, of course, Medicaid. It's not enough just to be poor. You've got to be poor and disabled, poor and a child, poor and a pregnant woman, poor and a single caretaker of a child. So now under ACA, all poor. You can be a childless adult. You can be a married couple. It doesn't matter. As long as you're no more than 138% of federal poverty, you qualify. So that's a huge change, and no more will Medicaid eligibility vary from state to state. And you may have heard 133%, right? The statute says 133%. Why do I say 138%? Because Medicaid, under the Medicaid program, there's a modified adjusted gross income. It's based on your modified adjusted gross income. There's a 5% adjustment. So the 133% actually translates to 138%. Now, some states challenge this expansion and said, we can't afford it. Medicaid's busting our budgets. And Medicaid is a big part of every state's budget. After K through 12 education, Medicaid comes in number 2. And it's fast growing and it's expensive. And states worry about that. So what Congress did, Congress understood this. And so what they said is, don't worry about it. For the first 3 years of the Medicaid expansion, we'll pick up 100% of the costs. And then we'll gradually reduce our share but it'll still stay 90% indefinitely. Right now, the federal government only picks up 50 to 75% of Medicaid costs, depending on what state you're in. Richer states like New York get 50%. Poorer states like Mississippi get more, like 75%. Indiana, we get 67%. So currently, we get a 2-to-1 match in Medicaid. Under the Affordable Care Act, it'll be 9-to-1 when at the minimum, and we'll get a infinite when we start out. So Congress, this was the assurance to the states, don't worry about the costs. Now, the other thing is, why is it unconstitutional? Because Medicaid's an optional program. No state's required to participate in it. So if it's too onerous, then you can opt out of Medicaid. And so all right, so let's do a little constitutional law, a little basics here. As I said before, Congress could not force the states to set up exchanges. And there's this principle that comes out of a number of cases. Congress can't commandeer state government. It can't say to the state government, here's a program that we think is great. We want you to implement. For various reasons, states have some autonomy. There's a concern that if Congress tells the states what to do and you don't like the law, you'll blame your state. And the state's not, why are you blaming me? Congress passed it. Right? I'm just implementing because they're making me. So Congress, the Supreme Court was worried about people, who are we going to hold accountable? Do we hold our congressperson accountable or our state legislators? So Congress can't tell the states what to do. But Congress can give incentives. And so they can say, I can't force you to have a Medicaid program in Indiana, but if you do implement a Medicaid program, we'll give you a lot of money. And that's what they did with No Child Left Behind. Right? No Child Left Behind is a voluntary program for states, but if they adopt the policies in No Child Left Behind, they get a lot of money. And the same thing with Medicaid. If you participate in Medicaid, we'll give you a lot of money. and states can either participate or not. So what's the big deal here? Well, here's what the state said was, we're in Medicaid now under the usual Medicaid. Now you're coming to us and saying, I want you to expand Medicaid. And if I don't expand Medicaid, not only won't I get these new dollars, but I lose all my Medicaid dollars. I can't, say, I leave your Medicaid expansion. I just want to stay with where I am. The Affordable Care Act said you had to either do all of Medicaid, old plus new, or none. And states said that's not fair. We signed on to the Medicaid under certain understandings, and now you're changing the rules in midstream. It's not fair to change the rules in midstream. And the court agreed. The court said you can't, when you're trying to entice a state to sign up for a program, you can't leverage their some other program. You can't, they signed up for Medicaid A, traditional Medicaid, and now to get them into new Medicaid, new and improved Medicaid, you can't say you'll lose your old Medicaid dollars if you don't come in with the new system. All you can say is to the states, all you can put at risk is the new Medicaid dollars. So in the end, the states can either say no Medicaid, good old Medicaid, or good old Medicaid plus expanded Medicaid. They've got three choices. And the main choice, no state's going to drop Medicaid entirely, because then they'd have to put the bill for their poor on their own. They wouldn't get any dollars, federal dollars. So now the question is, will states pass on the Medicaid expansion? Now, it looks like Governor Pence and the Republicans in the legislature are trying to prove me wrong. But I'm going to stand by it. I don't think in the end we will pass on Medicaid. And even if we pass on it this year, history tells us that states, in the end, sign on to programs like the Medicaid expansion. Because it really is a good deal. Right? This is a better deal than traditional Medicaid. As I said, instead of contributing $1 to $3 for every state Medicaid dollar, the federal government's going to do $9 to $10 for every expansion dollar. So it really is a good deal. If we pass up the Medicaid expansion, right, this is really penny wise, pound foolish kind of thing. We save $1 and we lose $9. That doesn't make sense. Okay, I'll get to what the governor's doing. And the state share doesn't kick in until 2017. And so the federal government has said to the states a couple things. One is you can wait. You can try it out for 3 years. Kick the tires, try it out, take it out for test spin for 3 years for free. And if you don't like it after 3 years, then you can pull back before you have to pay any money. So they can do that. The other thing about it kicking in until 2017 is, the budgets don't look so good now, but in 3 years, state budgets are going to look a lot better. And what about that 10% tax cut anyway? We have the money. We have a surplus here. Okay, so states have time to plan for their economies to recover. But here's the other thing is hospitals are very unhappy at any suggestion that their state's not going to take up the Medicaid expansion. Because the deal with the Affordable Care Act, remember, this was an omnibus bill with 2,000 pages of provisions. And what the hospitals who signed on, the Medicaid expansion was very important because how are we going to fund this Affordable Care Act? Well, there's major cuts in Medicare reimbursement for hospitals. Over time, the rate of increase in hospital reimbursement is capped. But hospitals are going to lose hundreds of billions of dollars over the next 10 years. Well, how can they afford hundreds of billions of dollars? Well, they know with the Medicaid expansion, they're going to get all these new paying customers, all these patients who they had to write off as uncollected debt. Now they will, so they make up what they lose in Medicare, what they gain in Medicaid. But if they don't get the Medicaid expansion, they still got to eat the losses in Medicare. And as the hospitals are or a nice way they phrase it is, do Indiana taxpayers really want to pay, right, for the Medicaid expansion in other states, and because we're still going to pay for it, and not for our own people, and then our hospitals are going to go out of business and we lose jobs. So the Medicare reimbursement, the other thing they lose is the disproportionate share funding, right? For hospitals that have a disproportionate share of indigent patients, so they have, again, they have non-paying patients, the federal government sends extra dollars every year, the so-called disproportionate share hospital funding, DISH funding. The DISH funding's been cut because with the Medicaid expansion, you don't have as many uncollected debts, unpaid debts. Now you've seen some estimates. The Milliman says it's going to cost $2 billion to do the Medicaid expansion, and the hospitals say no, it's more like $500 million. But here, one of the major reason why you see different estimates is this woodwork effect. What Milliman is including is all the costs of Affordable Care Act, not just the Medicaid expansion. And the big cost to the states is not everybody who's currently eligible for Medicaid signs up. For various reasons, it's complicated to sign up, there's a stigma. So we have a lot of people eligible for Medicaid now who have not signed up. And since the Affordable Care Act, right, there's this mandate to buy insurance, even though Medicaid eligible people are exempt from it, they may think they have to buy it, but there's going to be a push to enroll people, it's going to be simpler to enroll. So all these people who are eligible now are going to come out of the woodwork, so-called woodwork, and start signing up. They won't get the 9-to-1 match, they'll get the old 2-to-1 match. That's the real budget. And they can come out any day now. They're eligible now, they don't have to wait till next year. So that's what states are really worried about. It's not the Medicaid expansion. But anyway, here's what I think is going on in Indiana. Well, I know what is going on in Indiana, and here's how I think it'll come out. Right, Indiana, we've got the Healthy Indiana plan that was passed, I think, in 2005 as what's called a Medicaid waiver. If you don't follow the standard rules for Medicaid, you want to do it the Indiana way, you have to get approval from the federal government. You got a waiver from the usual rules of Medicaid. And we got a waiver to expand our Medicaid program in the Healthy Indiana plan. We passed a cigarette tax, and we could cover people up to like 200% of federal poverty. And the federal government said that's okay. We had a Bush administration that helped. But anyway, now Indiana wants to use the Healthy Indiana plan for the Medicaid expansion. And so far, the federal government has said no. Now, why has the federal government said no to Healthy Indiana? Because Healthy Indiana is based on the health savings account approach. And the idea with health savings accounts, we want the insured person to have skin in the game, so that when they're trying to decide to go to the doctor and how much to spend, it's their money, not other people's money. And they'll be more cost conscious. So that's Healthy Indiana. And the problem is the federal government isn't very enthusiastic about having poor people have to pay for their health insurance. Because if you look at what the individual share under Healthy Indiana plan, it can be unaffordable for a lot of poor people. So the government is saying, look, we're willing to be flexible, but you can't ask people to pay too much money. And Indiana so far is saying we want to do Healthy Indiana plan as is. But there's a lot of bluffing going on here, I think. So my guess is we'll get a deal in the end. And Governor Pence will be able to say, we're doing it our way. We're doing the Healthy Indiana. We're not following the federal government mandate because he's campaigned against the federal government all these years. So I think he'll find a way to compromise on the terms of the Healthy Indiana plan. As I say, because the hospitals are going to put a lot of pressure on them. And you all too are, right? I mean, healthcare providers. So I think we'll get it in the end. But we'll see. I hope I'm right. The final thing I want to say is, in the end, we had all these challenges. We had a couple of years of, following them through the courts, and is this going to stand or not? And it turns out the legal challenges, the one legal challenge that's got the most likelihood of succeeding is the requirement for religious institutions or people who businesses where the owner has religious scruples to cover contraception. I don't think it's so much a constitutional problem, but there's a called Religious Freedom Restoration Act, which Congress passed several years ago to protect the religious beliefs of people and to protect them from government mandates. And I think that one has a reasonable chance of success. So we'll see as they move through. But it wouldn't surprise me if the courts say, no, you can't force people who have religious beliefs against funding contraception. You can't force them to offer it as part of their insurance coverage. But all the other legal challenges are mostly falling by the wayside. There are a few left. But the biggest threat to the Affordable Care Act is not the legal challenges, but there are some, design defects, right? President, as Obama said, if I were starting from scratch in the United States, I'd do single payer. But we're not starting from scratch, and he wanted to get something through he thought could pass. So we have sort of just an expansion of our current system. And of course, in our current system, we don't give people a right to coverage. We give them a right to care. Unless you're a veteran or a Native American, we do give you a right to coverage. But for most Americans, if we give you insurance, we give you coverage, you still got to find your own doctor. And as you know, it's often not that easy to find a physician who will take Medicaid, and it's even getting harder for Medicare. So that's one problem, whether we can give you insurance, but will we really give you the access you need? The other thing that worries me is the interest of the poor not linked to the interest of the financially secure. And this is kind of an important theme in benefit programs in our country. That the programs that are most successful are programs where rich and poor benefit alike. Social Security works pretty well. Medicare works pretty well because everybody gets into it. So when Donald Trump is trying to decide whether he wants to, encourage his legislator to support Medicare, he knows he's going to get it, and even if he doesn't bother with it, he's got family members who will. But Medicaid, he doesn't worry so much about Medicaid because he doesn't have a personal stake in Medicaid. So Medicare is much better funded than Medicaid. And I mentioned the original housing program. When the federal government set up housing in the 1930s, it wasn't means tested. You didn't have to be, it was the Depression. Everybody was poor, I guess. But whatever. It didn't, but they didn't make it means tested. Even if you actually had a job in the Depression, you still qualified for housing. It was very nice housing. And then when they made the program permanent in the 1940s, they made it means tested. It went from nice garden apartments with child care facilities, and libraries, and a lot of nice amenities, green space, to those ugly high-rises that had to be torn down because they were just for the poor. So we see this, and that's the same with the Affordable Care Act, right? Most people will still get their insurance from their employer. The people who get it because of the Affordable Care Act are people who are too poor to afford it on their own. And so the question is, will, over time, Congress be willing to maintain the Medicaid program funding? Will they keep it at 90% over time? Will they fund the subsidies for people who buy it on the exchanges? You're in 150% of federal poverty, you have to buy it on the exchange, you're not eligible for Medicaid. Will the subsidies to help you buy it on the exchange be maintained over time? I think that's a big worry. And then also the federal-state partnerships don't work as well. And this is in part a federal-state partnership. The states vary in how generous they are. And then finally, Affordable Care Act, there are a lot of pilot programs, and hopefully they'll work out. But Affordable Care Act was much more about putting more people into our current system, which is kind of broken, rather than actually doing a lot to fix the system. And that's pretty common. This Congress wasn't unique. Medicare did the same thing when they passed Medicare. They knew they were creating inflationary pressures that were not sustainable over time. But they said, we'll deal with that. Let's just get Medicare, get the access taken care of now. We'll deal with costs later, or somebody else will deal with it later. Massachusetts, when it passed this reform, did the same thing. Let's take care of access now. We'll deal with costs down the road. And the Affordable Care Act does that too. So, anyway, I think we have a few minutes for questions, Elise. Be happy to take some. Uh-huh. Okay, so you have this mandate to have insurance. Right. So you have this mandate to buy insurance. How will the government know whether you pass muster or not? And I think what you're supposed to get is, you know how you get various 1099s and documents for tax purposes? And I believe what you're supposed to get is a document like that that certifies that you have insurance. And therefore you can either file it or if the IRS asks for it. But I'm pretty sure that whoever provides you your insurance is supposed to supply you with some kind of official document, like a 1099. Right. So on this, hospitals putting political pressure on, not all hospitals in the same boat. Some have more poor patients. Some have more Medicare patients. Um, so are there hospitals that really won't care about the Medicaid expansion because they weren't expecting any new dollars from Medicaid anyway, and they don't have just. Yeah, I suppose that's true. That some hospitals are going to, all hospitals are going to suffer from the Medicare cuts. But you're right. If they weren't expecting too many more Medicaid, I don't think that's going to affect the pressure because I mean there is this hospital association that's going to put a lot of pressure on, and so I don't think that's a big concern. You're right. If it's only a few hospitals that are affected, but the fallout is going to be. And one of the things they're going to say is, for some hospitals, this may make the difference between being able to stay in business or not. And if, communities don't like to lose hospitals. We probably have more hospitals than we need. But maybe here's a time where it's good, because at least it'll help with the Medicaid expansion. So you're right to the extent that, I don't think though that that's a big enough problem. I think there are enough hospitals, important hospitals. The Hospital Association is working very hard on this one, so I don't think that'll be a problem. But you're right, in theory, that could undermine it if there are hospitals that aren't worried about it. Uh-huh. So if you're going to have an exchange, are there certain kinds of requirements as to what kind of plans, how much flexibility? So there are some minimum standards to offer your plan on the exchange. You have to cover what are called essential health benefits. So you have to cover hospital care and doctors and drugs and diagnostic tests. And there's a list of 8 or 10 categories of health benefits that you have to cover. And everybody's got to cover that. Now, these are just general categories, so there's got to be some fleshing out. And one of the decisions that the Health and Human Services made was that they were going to leave it to the states to refine the categories. So is acupuncture going to be covered? And some states will have acupuncture, some won't. Everybody's going to have hospital care. You can't have any, now you also can't do any more of the annual caps on total coverage or the lifetime caps. You can't say only $1 million lifetime only. So that, you have to meet that. Then there are limits on how much you can ask people to pay out of pocket, right? And there are different tiers. There's bronze and silver and platinum, I think, are the different tiers. And so you have to, the plan has to cover at least 60% of the expected costs. That's the bronze. At a minimum, you have to be a bronze plan, and you have to cover at least 60%, and you can't have more than 40% of the costs, shift the cost to the individual. And then there have to be caps on out-of-pocket costs for the year. You can't expect them to pay $50,000 in co-payments. So there are, you have to operate within certain restrictions, but then if you meet the minimum standards, then insurers can have variability in the terms of their plans. So some can be more generous than others, some can be closed panels, some can be, you can have health savings accounts, so on. So, other questions? Okay. Oh, the independent, all right, so they set up this independent payment advisory board, which is designed, so one of the concerns is how do we keep Medicare costs under control over time? And there's supposed to be these targets, and if these targets aren't met, then this advisory board is supposed to implement them, send it to Congress, and the Congress has to, either come up with something different or they'll go into effect automatically. And this advisory board is supposed to, develop recommendations for Congress, or how do we contain costs over time. And this has gotten a lot of criticism. If in a Romney administration, they might never made the appointments because these things, steps aren't taken, don't need to be implemented. I don't know that they're up and what they're doing yet, but I think it will be implemented. And, it's going to be an interesting question how effective they are, because Congress can always ignore what they say. All Congress has to do is say, we're not. Well, a good example, right, is the physician. Remember, every year there's supposed to be these reductions in physician reimbursement under Medicare, and every year Congress suspends them. And it looks like they might finally do a permanent fix, but they've been suspending them year after year, and there's this, all this money that supposedly is going to be claimed at some point from doctors. It looks like they're going to eliminate it finally. So we may see the same kind of thing with this advisory board, that they may come up with some recommendations and Congress can ignore them. But so far, it seems, I think it's going to go into effect, try to do what it's supposed to do. But yeah, it's uncertain how great an impact it's going to have. There's also the comparative effectiveness board, which is supposed to promote comparative effectiveness research, so we have a better sense of what works and what doesn't work. And people claim that that's going to be the death panel kind of thing. And then again, in a Romney administration, that might have been blocked. But in an Obama administration, it should be more favorable to that. But I can't remember which panel where Congress was not funding. So it was appointed, but they couldn't meet because Congress wasn't funding. I can't remember. It might have been one of these two. So that's another thing. Congress can just prevent them from operating by not allocating funds, authorizing funds. Yeah, so what if you earn too much for Medicaid, but you still can't afford insurance? So the way it's structured is up to 138%, you qualify for Medicaid. And then if you're between 100 and 400%, you qualify for subsidies. So if you earn 150%, you'll get a generous subsidy. If you earn 350% of federal poverty, you'll get a much smaller subsidy. And it's, hopefully, the subsidies are large enough to make it affordable. Now, they won't be. Right? Not everybody is going to be able to manage. And the statute does say that if you can't afford it, even with the subsidies, you're exempt from the mandate. So there will be, I mean, the estimate is there still will be, I think, 20 million or so people uninsured, even after the Affordable Act kicks in. Because there will be people who don't get a big enough subsidy to afford it on their own. So this is not universal access. We're not going to get to universal access. And that'll be a big question to see. There have been people in Massachusetts where the subsidies haven't been enough for people who earn $70,000 a year. $70,000 when you got to pay $15,000 for insurance, that may not work, especially in Massachusetts where the cost of living is so high. So yes, it's not gonna. There are going to be gaps, but the statute at least says for the gaps will give you an exemption. There's another lawsuit that I don't think is going to succeed. There's this little twist out there. When Congress wrote the statute, it said that the subsidies will be available for state exchanges. And what about the federally run exchanges? No subsidies? Well, if you read the whole statute, clearly the intent of Congress is to make subsidies available for if you buy insurance, whether it's run by the state or by the federal government. But there is a lawsuit claiming that if your state has a federally operated exchange, your residents are not eligible for subsidies. I don't think that one will succeed, but it's possible. Okay, good question. Right, under current Medicaid, you've got these different categories, poor and disabled. Now, if everybody's eligible up to 138%, will we just have one way to sign up for Medicaid? And unfortunately, no. It will be a streamlined process, but if you qualify under existing Medicaid, you will still be under the current categorical approach. And the reason why is Congress does not want to spend 90%, have the federal government have to pick up 90% for everybody. So you'll either qualify under traditional Medicaid or under expanded Medicaid, and that's unfortunate complication, but that's the reality, and as I say, otherwise they couldn't have afforded to give the 90% match. Oh. Okay? Yeah, when do they have to decide on the expansion? If they want to decide this year, they have till the end of April, this session. Now, the federal government doesn't say you got to make a permanent choice this year. If they decide no this year, they can come back next year. They can come back at any time. So the government, they did try to set some deadlines like on exchanges, and they've tended to eliminate. So if the governor and the legislature decide, even though they've told the federal government we want a federal exchange, they said tomorrow we want a state exchange. They say next year they can do it. So even if they pass up Medicaid now expansion, they can come back next year, and then we'll lose a year of traditional Medicaid of the expansion, but we lose a lot of money, yeah, because over 10 years, it's like $8 billion for the federal government. For the state of Indiana, it's $8 billion over 10 years. The state has to pay, the estimates vary, but maybe $500 million to get $8 billion. So yeah, but we've done it before. We've passed up lots of federal dollars because we don't want to follow the federal government's mandate. Hopefully, not this amount. More, it's like 5 or 10 million a year. But 800 million a year for 10 years. That's real money, as they say. How's the federal government financing all this? Well, about half is from cuts in Medicare. The reimbursement cuts to hospitals, reduced funding for the Medicare Advantage, which is the private insurance part. You can buy instead of getting traditional Medicare, you can have the government pay your premium for a private plan. So they've been overpaid, basically. So about half the funding comes from reimbursement from Medicare, hospitals, and other facilities, not physicians, but facilities, dialysis centers, nursing homes, whatever. Medicare Advantage, and then there are various taxes. One of the things is to make our tax code more progressive. Wealthier people are going to pay higher taxes, higher Medicare payroll taxes, higher premiums for Medicare. If you're wealthy people already pay higher premiums for Medicare Part B, that's going to go up even more under the Affordable Care Act. Taxes on medical devices, taxes on tanning salons. There's an assortment of taxes to kind of fund it all.